so I'll just work through this.
Okay.
If I can say hello first, I'm Amanda Proud. I know I've met quite a few of you. Hello. Myself and Juliet were asked to develop a training package to support the STOMP initiative. So I just want Juliet to say hello as well, please, Juliet.
Hi, I'm Juliet Lara. I'm the Positive Behaviour Support Manager for National Care Group.
Yeah, thank you, Juliet. Myself and Juliet are working this together. I'm taking the first few slides to talk about the actual project, and then Juliet's going to take the last couple of slides and chip in where she's needed. Before we start, I just want to mention that a lot of the people on the call will already have a lot of information around this subject. And, you know, when we're presenting something like this, I just want to be mindful that some of you will know it off by heart, and we'll go over material that you'll know really well. But some people may not know some of the parts throughout the slides. So if you can bear with it, if you know it all, and just, you know, if you've got something that you would like to chip in, please, that's not a big group, so we can actually just perhaps have a bit of discussion around sort of the subjects as well, make it a bit more than just me talking. Is that okay? We are going to talk about some subjects that are quite hard-hitting and quite uncomfortable reading, really. So I just want to acknowledge that some of you may know people that are on medications that perhaps cause harm to them or that shorten their lives, or you may in fact have colleagues or have these medications yourself. And whenever I've done any training like this, I've usually got somebody in the room that it's quite a sensitive subject for. So I am trying to be mindful, but we do have to discuss these hard-hitting subjects. So if you can just bear with me, and if you feel uncomfortable or want some advice at the end, please stay online and I'll be happy to talk about the medication side of things. So the STOMP initiative is what it says on the tin: stop over medication of people with a learning disability, autism or both. So there is another STAMP, which is the for paediatrics, but we're just going to focus on STOMP today. My notes are actually not print-oppable, so I might look to the left and right a bit, so bear with me. So the aims of our programme today is just to increase understanding and awareness of the STOMP agenda, and for everybody who works for NCG to understand that NCG have signed up to a pledge that they've agreed to support and guide and advise around the STOMP agenda. So we do need to learn all about it. We are going to increase our understanding and awareness of the impact of psychotropic medication on physical health and well-being. We can't learn about STOMP really without really truly understanding the impact it has on health and well-being. And there's some hard-hitting statistics really around that, which are very uncomfortable to read out. And then towards the end of the session, we'll look at how we will evidence our commitment to STOMP through our report writing, and Juliet's going to help me with that side of it. So I got this flying in actually and got all clever with my preparations on my slides, but it's been tidied up by our corporate pods in IT. So it's not going to fly in and be interesting like that, like I originally had it, because otherwise it's a bit wordy. Now, it looks a bit wordy, but I will just read it out. This is what we've pledged to do as NCG and everybody that works here. We will actively explore alternatives to medication. So please bear in mind with that one, STOMP is stop over medicating. We're not talking about stopping medicating people. We're looking at maybe looking at the over medication of people. We know that lots of people that we care for and support will need medication. We're not moving away from that. It's just being mindful really to look at alternatives. We'll ensure people with learning disability, autism or both of any age and their circle of support are fully informed about their medication and involved in the decisions about their care. I'm sure that's your bread and butter, and I'm sure that's what's happening in services already. We will ensure all staff within the organisation have an understanding of psychotropic medication, including why it's been used and the likely side effects. And we're going to touch on that today, and I've kept it very straightforward and simple as possible. I can go into more depth if you want me to, if you've got any questions when we get there. We will ensure all people are able to speak up if they have concern that someone is receiving inappropriate medication. And that's a big one when you're working in health and social care, that sometimes you're up against a prescriber that's quite insistent, and a GP, and sometimes we've got to learn a way around that and how we can actually support our people to get the best care and treatment from them. We'll maintain accurate records about a person's health, wellbeing and behaviour. Juliet will touch on that again later as well. We'll ensure that medication, if needed, is started, reviewed and monitored in line with the relevant NICE guidance. I know everywhere I've visited so far is really on board with that already. So a lot of this you'll already be doing. And we'll work in partnership with people with a learning disability, autism or both, their families, care teams, healthcare professionals, commissioners and others to stop over medication. So I don't think there's anything new in any of those bullet points. I think we're all signed up for that. I've been signed up for that for 40 years of my career, so I'm sure you're already nothing new there. I mentioned the STAMP, but I don't think we work in younger people, but you may actually, it's still important to understand that you might be working with somebody who has a young person, or you may know a young person who is on sort of these medications that cause harm. And it's worthwhile just knowing that is something that you can perhaps support somebody with, although we don't have them in our service. So why STOMP? This is the hard-hitting stuff that really upsets me and has done for a long time. On average, on an average day in England, between 30 and 35,000 adults with a learning disability, autism or both, are taking prescribed psychotropic medication when they don't have a mental health condition. So that's quite shocking statistics, and I can sort of, hopefully you sort of be nodding at that, and you probably already know it. This statistics always upset me because I've got family members who sit in this category, and I've already lost a couple of people over my career where this has happened. People with a learning disabilities die significantly younger in England and Wales than people without a learning disability. Men with learning disabilities die 13 years on average earlier than the general population, and 20 years earlier for women compared to the general population. I know you're on mute, but please nod if you think that's shocking. I mean, you knew that already, I'm assuming. It's shocking statistics, and I will go on we'll talk about why that is the case and what we can do about reducing that gap. People with learning disabilities are 2.5 times more likely to die before the age of 50. I'm going to use some, I know it's going to be on Zoom. I much prefer an open forum where we can talk and perhaps share experiences, but it's possibly going to be just like me talking, but I'm going to give you a scenario. About 35 years ago, I worked with young men with learning disabilities and psychiatric dual diagnosis. So it was a forensic unit. So they would have been 25, like I was 25. And now late 50s, I met a gentleman in a different job that I do, and he's my age, 58. And we were reminiscing about our time when we knew each other all those years ago. Now, he's the only survivor out of a massive cohort of people I cared for, because they all died at 40. We were reminiscing, and he said, Amanda, do you remember so-and-so? I do. He died, 48, heart attack. Do you remember so-and-so? Yeah. Died, diabetes, had a stroke, you know. And out of the 15 people that we talked about, he is the only survivor at 58. The rest of that cohort that I looked after did not make it to 50, let alone 58. Now that, I don't know about you, but that's kind of upsets me quite a lot to know that he's the only survivor. And the only difference between me and him at 58 is he was diagnosed with schizoaffective disorder and had a mild learning disability. Now, I don't think it's fair. And I'm not saying that we should, we're not going to save everybody. And I'm quite proud of the fact that in my 40-year career, one person survived because of some of the interactions I had with him when he was younger, because of this is what we were talking about. So we're not going to get all our individuals that we support to live a long and healthy life. But if you just have influence on one person in the whole career that you have, then you've done something amazing. So just bear that in mind. It's not about saving everybody and making everybody live to the 100. It's just learning a little bit more and being a bit more aware of the statistics and trying to be a bit more mindful to help people live a healthier life. Okay, so I know it's a bit emotive, and I've got a few stories like that over the career that I've had. So I just want people to be a bit sort of mindful, that's all. There's a bit that they've taken off here that sorry, I'll go back there. The little tiny bit down there, CIPOLD, there was that stands for Confidential Inquiry into Premature Deaths of People with Learning Disabilities. It was funded by the Department of Health, and you may have heard of it. It was 2012, it's quite a long time ago. But that was a long time ago, and nothing's changed since then. And that's why we're looking at STOMP and some other inquiries that are going on. So since 2012, although that confidential inquiry was put out then, that's nearly 10 years ago, and things haven't improved that much. So we need to really get on top of it. So the reality, why are they dying younger than us? Access to treatment and emergency. There are long waiting times for treatment and lower treatment rates for people with learning disabilities. I honestly thought that that had improved. So when I was training 30, 40 years ago, if I became unwell and needed an operation, my operation would take priority over somebody with a learning disability. Now, don't you think that's appalling? I want to survive and I want to have an operation, but I don't think my care and treatment should go above somebody that happens to have, I don't know, Down syndrome or a learning disability. So I was sort of hopeful that over all these years that had changed, and it really hasn't. It's changed a little bit, but it hasn't changed that much. And I think you'll all know from the COVID experience, and you might have experiences to share, that people were put on end of life care or not even offered COVID care and treatment. They were sent out letters into community about saying, if your relative gets COVID, don't take them to A&E. Because it's a small group, has anybody got any experience that they're willing to share where perhaps they've had to fight for the rights of their individual, where perhaps me and you would turn up and get treatment? Has anybody got any experience of that happening? Is anybody willing to? Abby?
I don't have experience of it like directly myself, but my partner was in the same a registered manager, and he managed a service where people had profound learning disabilities.
Yeah.
And one of the people that they support went into hospital, and when he got there, he found that they'd put a DNR in place.
Yeah.
And so he challenged like the ward sister on it and said, like, you know, you can't do that. There's been no discussion with the family, like with myself or anything like that. And like the doctor come over like and basically said that that's what they would be doing. So he went to the patient liaison service and fought it. When he went back the next day, they'd also had, you know, they got the whiteboards above the bed. They'd got on there something like ham sandwich or something like that for lunch. And this person was peg fed.
Oh, wow.
And so like he made a complaint about it and said, you know, clearly nobody given this guy. Now this guy was only 33, and himself and the patient liaison, they fought it. He had the treatment that he needed, and he made a full recovery. And as far as we're aware, you know, he's still alive and sort of,
and that's because your husband was his advocate. You know, that we have to advocate in those situations sometimes, and you're sometimes up against some highfalutin professionals who have already made a decision that are often not wanting to pull back on that decision. It's very, very frustrating. So, and I'm afraid, Abby, there's lots of examples like that. One of my colleagues is a mum to, she's in her 60s, and she's got a young son. Well, no, he's 40, seems young now, but he's got very profound learning disabilities, and he looks, I don't know how to put this, but he looks as if he's got very profound learning disabilities, if I can put it that way. He's a well-loved, amazing young man, goes on holidays with his family, you know, he has a really healthy, good life. But outside of his mum's care and support, he had a tumble, and before she could rush to A&E and get to him, they'd already decided to not resuscitate him. Because of the way he looked. There was no evidence as to the reason why, other than they were going purely on him looking quite disabled. And he went on to, thankfully, because his mum was there and able to advocate for him. But I'm afraid those decisions are still being made, and we're going to have to fight against them as best we can, really. And we'll go on to how we can do that. That's Juliet's bit. So going further on, physical health. People with mental health problems and learning disability or physical health needs may not be recognised appropriately and addressed. Now, the bit I put in brackets is a bit of a term that it's a bit of a clinical term, and I can only apologise for that, but I will explain it, and you'll I'm sure you've probably got examples of this as well. Diagnostic overshadowing is where you've probably got some people, and I've met people that behave a certain way, And sometimes the medical diagnosis gets overshadowed by their behaviour. I'm just giving an example. So somebody that's sort of always screaming, you know, perhaps their presentation is, or the way they behave is always to be quite loud and boisterous and screamy and whiny, and, you know, and it can happen in your own life as well with children or with people that you know that perhaps are always a little bit inclined to over-egg how they're feeling, perhaps physically, so that when they are very physically unwell, we don't take much notice. So some of our people with learning disabilities, you know, I've heard it said to me, oh, she's always like that. Oh, they're always like that. That's how they are. Or in older adults, sometimes they'll say, oh, she does that. And she pretends she can't move her arm. And I'm thinking, well, you can actually fake being able to hold your arm down on one side, but you can't make your face fall. And so there are examples where people have perhaps had a stroke, you know, where they've lost the use of their arms, and actually it's a medical condition. So it's just being mindful that it might be something new. And again, Juliet will get to how we can perhaps be really mindful about that when we're doing our recording and monitoring. So the premature mortality rates significantly higher in people living with mental health conditions and learning disability. And that's where the 20 years too soon comes from. In serious mental illness, they die 20 to 25 years younger than the general population, as do our learning disabilities. People with severe learning disabilities. And when I always remember in 1950s, our level of how old we're going to get is about 65, 70. You were kind of got 65, you were very elderly. That was the 1950s. Things have moved on now, and we're expecting to live to 85, 90, aren't we? So if you think about it, the people with learning disability and serious mental illness, they're still in the 1950s. They're still dying at 55, 60. So if anything we can do to close that gap, I can't say it enough, really. Stigma and discrimination, Abby's already given an example of that. The underpinning belief that physical health treatments will be, you know, they'll decline them. I don't know if you ever met anybody that said the GP won't even offer the test because they'll say, oh, she won't have it. She's declined before. She doesn't like to go for the smear test. And the assumption's made that actually they won't turn up. So, you know, it's that kind of always trying to go against that perception of people who are offering this care and treatment, the GP, the hospital, and actually they should be given the same amount of care and treatment, obviously, as us. My PowerPoint's been changed, so I just want to read this out. There was a project called Death by Indifference. I don't know if you've ever heard of that. It was the National Learning Disability Charity, MENCAP. You'll have all heard of MENCAP. They did a big report in the 80s and 90s and into the 2000s. And death by indifference, 74 deaths and counting. This found institutional discrimination in the NHS. And that was found to be true, and the discrimination is still happening. So we do have to fight against that in everything that we do. The charity's latest report confirms that although some positive steps have been taken in the NHS, many health professionals are still failing to provide adequate care to people with a learning disability. And they believe that this is directly linked to institutional discrimination. So they're big, heavy duty words, but at the end of the day, we've got to fight that discrimination for the people that we care for, that we support. I know these are wordy things and it's me just talking at you, so I apologise for that, but I think it's really important to capture why it's so important that STOMP has had to be developed. So there's now a Learning Disability Mortality Review Programme, and you'll see it written as LEDR, L-E-D-D-R. It's been commissioned to improve the standard of quality of care for people with learning disability. And I don't know if any of you have signed up for it or got involved with it. I was looking at perhaps being an investigator or a reviewer of deaths. So now all deaths of people with learning disability will be reviewed to try and look at, this should have happened years ago, but thankfully it's at least happening now. Everyone involved in care of learning disability can support people to live happy, healthy lives. This is their words as part of the letter. And annual health checks, reasonable adjustments, and stopping over medication of people, making sure that reviews happen and action plans are acted upon is the most important part of the agenda. And you'll see STOMP sits under that. That's why I put it in there. Care staff can take learning from these reviews. So when something happens nationally, NCG will get their report and it will come through as a learning event, and hopefully prevention is better than cure. I've put at the bottom there as a last bit because it's shocking, and this is one thing that again is very close to my heart. The third annual report, which was published in 2019, identified that 12 deaths with constipation was recorded as cause of death. Constipation. I don't know if anybody's had any dealings with that as an individual that's actually died from constipation. I mean, having that on your death certificate of somebody that you cared for is quite shocking, isn't it? And where I used to work, they did have an event like that. I wasn't, directly involved in it, but I was certainly involved in the fallout from that. And I don't want to be too gruesome, but does anybody understand what happens when you die from constipation? It sounds like an emotive subject. Anybody help me out? And I don't want to be too gruesome about it, but basically, the person that I had to review the care of was so constipated it was to their chest, and they were vomiting in pieces. That takes a long time for that to happen. Of course, you don't die of constipation, you die of sepsis. You die from heart failure because your heart can't, your body goes into shock, and it's a big medical emergency, obviously. But for that to happen, it takes weeks and weeks for that to happen. And then they have to look into why and what we did to help prevent that or recognise it. Myself and Juliet were talking about this morning, and our older adults, perhaps with dementia or somebody who can't communicate how they're feeling, we have to just be mindful of constipation as being a massive subject and not take it to underestimate it. And it is shocking, isn't it? And I'm sorry to be a bit gruesome about that, but I don't think we can get around it. When we're talking about the annual health checks, does anybody know, does anybody have their annual health checks themselves? We're all entitled to them. No. What I've printed off, this is a really good one that I don't know how to do it to link it for you. So I've just actually put it on the next PowerPoint slide. So I'll show you, you'll know it when I show you. Everybody in the UK is entitled to population screening. Now, once I got over 50, you get a letter or a message from a GP, okay? So I'm entitled to a certain amount of screening after a certain age. I thought my GP was being a really helpful, kind GP, because he sends me texts that say, "Hi, Amanda, you've missed your whatever." And I thought, wow, my GP really likes me. He's sending me for my screening. But as a quality initiative, he gets £250 every time I turn up. So every time we turn up for one of these screenings, that's why they're so keen on us attending. But the bigger picture for this is that if we can capture people, if they can capture me as a younger person to be more healthy, then I won't cost as much when I'm in my 60s, when I when I develop all these awful conditions. So if they can, prevention is always better than the cure. So if you look perhaps at some of these, we're working in healthcare and social care. You're caring for people, whether it be whether they're living in their own homes and you're supporting them, or whether they're in a nursing home. They're entitled to these, and our responsibility within that is to remind, advise, and it's good for you all to know that, for example, the top one, abdominal aortic aneurysms are offered to any men over 65. Now they'll start to get the letters from their GP as soon as they turn 65. So if you're caring or supporting for somebody that's that age, we should at least in our records or in their care planning or in their whatever processes you use, write that they've had it, or say that you've suggested that it's come through. Would they like to attend? Maybe show some support to get them there. And that's our responsibility to try, isn't it? If they've got capacity, they can decline it. I did own up to Juliet this morning. I keep getting mine to go to a cervical screen. I haven't been for 5 years now. That's me with capacity, not kind of getting round to it. But if I was in your care, under your care or your guidance, I would hope that you would sort of say to me, "Oh, Amanda, have you been? You're over a certain age." And it's not reasonable just to see it written once in the progress notes. You want to see maybe you tried a week later or a month later, or have it in the diary to suggest it a couple of months later. Has anybody got any examples that you can perhaps share where you've supported somebody to go for one of these? Anybody?
I've never heard of one of those AAA screenings, I'll be honest.
No, Abby, and that's fine, and that's why I'm doing the training, because I hadn't, you know, until I was doing this, I can sit here and look all clever and what have you, but at the end of the day, I didn't know that I was entitled to diabetic. I'm not diabetic now, thankfully, I reversed it, but you know, why would we know? Because you're not a 75-year-old man or a 65-year-old man. When you get over,
no, but there's 3 people over the age of 65 here at Coppice, and like there's nothing in their files to suggest they've been invited to.
And now what are you going to do about it, Abby? Fight the good fight.
Exactly.
Ask the GP. An older men can self-refer, it says there, and this is the NHS. There's loads of these on the Images website you can choose to use for your service users that are perhaps less able to understand words. There's loads of different images that you could use to support your individuals. They break them down into individual ones. So the bowel cancer screening one, it's a scary word, bowel cancer screening. You might not want to scare your service users by using that, but there's other bits on the internet that you could look at and sort of say, right, there's pictures, and you know, to guide your services to whatever service you have. You can use different, well, everybody's got their different ways of understanding them, haven't they?
Sure.
But what we do need to see that as soon as a man turns 60, they get a little brown envelope, and it is brown envelope, with all the little gadgets within it to do a poo sample. Now, they tend to end up in the bin, you know, and lots of gentlemen that I know who have had to turn 60 pop it in the bin, and I'm saying it's so important just to capture that. We're perhaps not going to actually scoop it up and do it for them, but you could certainly start to try and get that in your care records, or whatever you want to call them. So I'll leave that with you to look at and just consider that actually we should be encouraging our individuals to ensure that they get their health screening, and that's all part of living healthier lives. Yeah, I did send that out as a separate sort of thing on email, but print off whatever one you find helpful. So getting into sort of, I don't want to be too sort of medical, but it is important to kind of go through this. So we've really got to all understand what antipsychotic medication, what the effects are on our physical health, and I'm not being horrible, but that could be us. You know, we might need this soon. Okay, you know, there's no guarantees for any of us, so we do have to be mindful that it's not just for our service users, our individuals, it could be our family members as well. I've done a very brief slide on this. You know, I don't want to overwhelm everybody with loads of terminology, but basically, as you all probably already know, antipsychotics are a type of medication which are available only on prescription to treat psychosis. That's what they're designed for. They are licensed to treat certain types of mental health problems, which include schizophrenia, schizoaffective disorder, some forms of bipolar disorder, severe depression, and psychotic symptoms of personality disorder. Now, we know they're being used for the reasons as well, which they've been developed and used for, which I'll get on to, okay? Just so we can get things in perspective, I did do a couple of quotes from people who take antipsychotics. So it's not all doom. This is a quote from a person who takes antipsychotics. I still take antipsychotic medication today, and I don't have a problem. I feel so much better. I know that they work for me. So, you know, that we're not saying that it's a dreadful medication. They make me feel calm, help me sleep, stop racing thoughts, and help blunt hallucinations. Meds don't make life perfect, just help me cope. Okay. I've got a lovely colleague that I work with who's the same age as me again. And the only difference again between me and her is she was diagnosed with schizoaffective disorder when she was 18. So she has taken antipsychotic medication for the majority of her adult life. She has all the illnesses that we're now going to talk about, and she's very unlikely to see 60. When you're 58, you don't want to know your lifespan is going to be 60. You want to be able to get the same lifespan as everybody else. It's not fair. When she started on her medication, she was a size 10. She's still beautiful in my opinion, but she went from a size 10 to a size 28 in 1 year. That's an 8 stone to 10 stone increase from starting the medication to in 1 year. What she talks to me about is, and she's happily married, she's got children, but she does struggle with her mental health. Now, she struggles more with her weight than a schizoaffective disorder. She doesn't actually have an issue with having a schizoaffective disorder. She quite welcomes feeling high sometimes, and you know, she talks about it quite openly. But the drama of going from a size 10 to a size 28, I don't know about you, but right now, if I was to prescribe you something that was going to put on 5 stone by September, would you'd be shocked at that, wouldn't you? Yeah, I wouldn't like that. So I'm telling you now, if I come into your care, please do a past assessment and try and do your best to help promote me so I don't put that amount of weight on. So how does antipsychotics work? Again, it's a very brief overview. I'm not going to go into too much detail. Antipsychotic drugs don't cure psychosis, but they can help to reduce and control some of the psychotic symptoms. The symptoms include delusions, hallucinations, such as paranoia and hearing voices. They do help control anxiety and serious agitation for people that perhaps, for example, there for feeling threatened, you know, that horrible feeling that they get. They help with incoherent speech and muddled thinking. There's a lot of science behind this, but I'm not going to go into it right now. They help with confusion. They help with violent and disruptive behaviour, and they do help to reduce and control mania. Okay. I'm not going to go into a lot of detail in this side as well, but it's just so that you know a little bit of the history of it. They're broken into typical antipsychotics versus atypical antipsychotics. Now, many years ago when I was first nursing, if you don't have to remember all this, I'm just trying to be helpful really. The first generation antipsychotics, they're called the older antipsychotics. That some of you look very young, you won't remember. Karen, I'm looking at you. You'll remember some of these. They were called the typical antipsychotics, and they're on the left. Okay. The atypical antipsychotics are your second generation, and they're the newer antipsychotics that you'll come across. You won't come across a lot of the older ones now, unless you're in sort of forensic psychiatric units and things like that. But in your services, you're very rarely going to look at typical. When you're looking down the atypical, I just was mentioning this to Juliet this morning. If you put A in front of anything, it means without. Okay, so the prefix A means it's without. So all that means is without type, atypical. So I'll just use another example of A, I just trying to be helpful really with my prefixes. If you put A in front of, say, sleep apnea, apnea is breathing. So if you put A in front of it, means without breath. So A in front of anything, if you just remember that, it means without. I might be teaching to the converted already, but always remember some of the prefixes like dis is DIS is also without. So if DIS is in front of something, it means without. So if you appear and then you disappear by putting a DIS in front of it, means you've gone. So remember, DIS in front of certain combinations of words means without as well. So I'll use a term. Does everybody know what phasia means? Phasia. So if you've got dysphasia, it means you have no speech. If it's DIS, yeah. So just remember those few little tips around prefixes and suffixes as well. Probably speaking out of turn, but try not to be confusing. A little bit around that. The older style on the left there can cause, when it says motor control disabilities, that is the serious movement disorders. You hopefully won't see any of that now, but if you see somebody maybe who's in age 60, 70, who were given those medications when they were younger, they're left with some very serious movement disorders, and they have the writhing, jerking movements all the time that they can't control. So again, you've got to be careful that that's not being masked by somebody that's then diagnosed with Tourette's, because they may have a Tourette's illness or diagnosis, and actually then some of the motor movements can be thought of as being Tourette's, and actually it could possibly be their medication. So we've got to be mindful. Natalie, you were looking as if you were going to say something, did you? No. So you'll see there again that they have more side effects, and the plus side is they have fewer withdrawal symptoms. So they're not, none of them are perfect. So if you look at the ones that you're likely to come across, they're less likely to cause a movement disorder. They have fewer side effects, but they have a lot more withdrawal symptoms. So none of them are perfect. We've moved into the right-hand side of the column, but now the advice is from somebody who's prescribing these medications. And if you're helping to support somebody on this, my lovely friend that I mentioned that's 8 stone heavier, she said if she'd been given the choice, she might have preferred to have a movement disorder rather than 8 stone heavier. So the advice now when they're considering an antipsychotic is to consider, does this person, you know, would they rather have, it's not a nice choice, is it? Awful choice. Do you really want to have a weird sort of movement, or would you like to get stone heavier? Horrific choice, really. So I'm just going to carry on. Sorry, I'm just going to confuse everybody. That is just, there's thousands of these online. I was just trying to be helpful really to get you to look at maybe some of the medications that you're likely to be administering, supporting, that somebody might be on. And it shows you there the side effects that they're likely to suffer from if you recognize any of these: risperidone, quetiapine, olanzapine, clozapine. It's just a useful sort of very small, punchy little thing to look at to just understand what they might be suffering from. So the side effects of the second generation antipsychotics, the ones that you're going to come across, we've talked about weight gain, dizziness, fainting, tachycardia is fast heartbeat. And it's not just a weird, you know, fast pulse wave. You call me pulse is going. It's a horrible feeling. They feel like their bodies are going way too fast for them. They feel weird on it. They get ECG changes, and that's why we'll talk about that separately. You need to be doing the ECG monitoring for people on antipsychotics. Sedation, and again, it's not just a little bit of tiredness. It's an overwhelming tiredness. That's why a lot of the people that you see are in nursing homes and perhaps hospital, they're all lined up around the walls, just nodding off in their chairs. Postural hypertension is what it says there: low blood pressure on standing up. And haloperidol, if you ever see that prescribed to anybody that you know, you have to be very mindful that sometimes that can cause a falls risk, because as they stand up, their blood pressure drops and then they drop to the floor themselves. I've ended up doubling up on here actually, so some of this is the same. Blurred vision, dried mouth, constipation. You know, we're giving them something that causes constipation, especially things like clozapine. If you've got anybody on clozapine, you should be monitoring their, at least asking them about their bowel habits. Glaucoma, dry mouth, dry eyes, blurred vision, urine retention, constipation, confusion, and sexual dysfunction. And some of your people that you're supporting that are on these medications will have all of the above. Okay. I was talking to Juliet this morning, and sometimes in our learning disabilities, I've heard people say, and I want to kind of really react, sexual dysfunction, you know, they're upset about that. And they're saying, well, really, why would that be a problem? Well, you know, yes, thank you, Abby, for frowning. I could, come on, Abby, you're frowning, speak.
I'm very passionate about, I honestly believe that more should be done for people with learning disabilities to explore their sexual wants, needs, desires, and that, but like we're all too scared of it. Like we don't know how to go about it and do it safely and right and that. But I wish there was more, because I'd be so on it. And that, like, because I think it's really important. It's part of, like, it's part of us as people, like human beings, and it's part of physical and emotional and mental wellness. And yeah, I just think it's really
Abby, I love your passion. I'm still passionate. I took some little rainbow stickers to a service, not now service, it was before I joined your service, and I wanted to share these little rainbow there were only little rainbow stickers that I'd pinned from somewhere that somebody I acquired, and I offered them to this company that I was involved with, and said, I brought these little rainbow stickers to put into the you know, into the windows or wherever, to show our support to the LGBT community. The senior person in the room said, you do realise you're working in older adults? That was the answer then, and I was
no older gay people.
Well, there's no such thing, and I was thinking, oh dear, I'm just banging my head here. So yes, I totally feel that for you, and certainly with regards to the antipsychotics, it is an issue for people on antipsychotics. So we get, you know, we've got to be mindful of all of the above there that you can see. I don't want to go too much into the clinical thing, but you do need to know if you're seeing these medications in use. It's just a slide that's quite useful to look at. When you see on maybe the prescriptions or the MAR charts that they're perhaps prescribed cyclidine for extrapyramidal side effects, you'll see it written as EFBPSE. Now, I just wanted to just quickly tell you how awful that is for people. You know, the cyclidine does help, for some of these conditions. So that's an old man there, a picture, but we're talking 20, 25-year-old boys, men that are walking like that. They're stooped gait, they're shuffling around, they're rigid, and they've got slow movements. Brady is slow, kinesia is movement. So bradykinesia, it's that kind of slowness that they do. They get tremors at rest and the pill rolling. So although that's an old man picture, that could be, I've seen 25-year-old blokes walking like that, and it's heartbreaking. The acute dystonia, you might see that. That's kind of quite scary when that happens. And that's the really serious facial grimacing, involuntary eye movements that go up, and that's sometimes can go into a crisis called ocular gyrocrisis, where their eyes can kind of go up. They get muscle spasms and neck, and it's awful, you know, and it's the people that I speak with and care for and know, and they said it's a horrible, horrible feeling. Then you've got sort of, I'm going down to tardive dyskinesia. That's more the first generation antipsychotics. So I'm hoping you won't ever see this. They're more my age group and above that were ruined by this medication years ago. And it's embarrassing. You know, people are trying to work with this condition, and they've got these weird, sort of very strange movements. Their bodies are jerking, and you know, they'll all of a sudden they'll put their arm up and it'll twist around. And it's such a terrible thing that they actually sometimes have been known to literally dislocate their own arms by the movement is so fast. So none of this is good news, is it really? So akathisia is one that you'll see, but I do want to talk to you about this because I didn't know this until I was told it. So I'm just trying to make you aware. You'll perhaps see some of your individuals who are very restless and they have trouble standing still and they're rubbing their feet, the pace in the floor. They seem like their feet and then rocking movements are all in constant motion. Has anybody experienced anybody that's got those sort of movements? So sometimes what you'll see with akathisia, with all of these things, the first three, the Parkinson's, the old man there, and the man with the rolly eyes, and the feet, they're reversible. They're reversible with medication and support. They are reversible completely. But sadly, tardive dyskinesia, the one on the right, bottom right there, that is irreversible in 50% of people. So that is, once they've got it, they'll live with that for the rest of their lives. So it's not possible to reverse it. The drugs like procyclidine that you've probably seen in your time caring for people is the drug of choice for the Parkinson's, dystonia and tardive dyskinesia. It can help. It can help to with the symptoms. But procyclidine, so be mindful of this because I didn't know this until fairly, recently. Procyclidine won't help with akathisia and it will make it worse. So when you see that they're asking perhaps for medication for their side effects, you need to really be recording in the notes what sort of side effects are you giving it for, because you need to make sure it's for the reasons that it will help. Because if it's restless, trouble standing still, pacing the floor and feet twitching, not only will it not work, it won't help, it'll make it worse. And I did actually write myself down, as I remember, actually I haven't written it down. You don't need to know this, but you may need to support your individual. It's propranolol. That'll help. Okay, so propranolol is more likely to help with akathisia than procyclidine. So you're not prescribers, you're not dispensers, but I don't think it hurts for you to know this if you're caring for somebody. Okay, and please be mindful of the overshadowing thing that we talked about as well, because some of these things are medication and extrapyramidal side effects. Some of them are illness. Some of them are their normal behaviours. So you've got to just be mindful when you're seeing this sort of these side effects. Just stop and think, well, is it that or is it that? Don't tie yourself in knots, but just open your mind to perhaps it being something else. The hormonal and sexual side effects. This is a medication that we're still talking about, second generation antipsychotics. Sexual dysfunction. Males cannot get an erection, and you're talking here. This bloke here is, and I've met people like this, probably 25. These are not old men. And they're more embarrassed by the breast tissue than having schizophrenia or having a learning disability or having whatever. And this is not weight gain. This is not pure weight gain. This is proper hormonal dysfunction, and this happens with a lot of young people. Oh, my internet connection's going off. I'm sorry. Are you still there? So chaps there get pop a breast tissue. Now that won't shrink back when he loses weight. He'll be left with that and having to have the operation like women have to reduce those down. Men and women get breast pain, women get menstrual irregularity, and they become have female infertility. So that's the challenge that they have sometimes if they have got capacity to decide, do I stay mentally well without these awful these awful psychiatric symptoms or behavioural symptoms, or do I have all of this? And you know, I sometimes wake up with a few moans and groans, and I think, well, thank goodness I haven't got this to consider in my life. So it is a bit of a shocking photo, but my daughter said don't leave that on there because and I said no, it's a powerful picture, isn't it, really? So there we go. The other side of it, these lovely, sorry, it's a bit of a depressing subject, isn't it? But I think it's got to be shared. The weight gain occurs more frequently in the 6 to 12 months of starting antipsychotic treatment. And when we talk about weight gain, we're talking, like I said about Rachel, she put on 8 stone in a very short space of time. There's an increased risk factors of cardiovascular disease and early death. And the second generation antipsychotics, especially clozapine, olanzapine, and quetiapine, are at fault for weight gain. So you'll be quite merrily probably supporting your individuals having these medications, but I think we just need to know behind the scenes what they're likely to cause. Please be mindful of clozapine. That's your that's when you well, all of them, but that's when you really ought to be doing bowel habit monitoring, at least asking if they've been to the toilet and things like that. So, and it's very short little bit there at the end there, diet, lifestyle, and switch to non-psychotic. Okay, so the biggest part that you can play in that is the diet and lifestyle, and supporting them under STOMP to perhaps consider maybe reducing their medication. And those 3 little tubes at the bottom there, that hopefully is a young person's artery, all free flowing and lovely, and the one in the middle is perhaps me because I'm a bit older than everybody. And unfortunately, that one on the right is possibly what your arteries look like when you've got metabolic problems. And you can see how blood would struggle to flow through that one on the right, which then puts your blood pressure up and has an impact on the rest of your body functions. I could go into more detail, but I won't have time today. ECGs are important, okay? Why are they important? I don't want to go again into too much detail on this, but for you to just know how important they actually are. And if everybody can see that pretty pattern at the bottom, that's your PQRST waves. You'll see them when you're doing an ECG. They all come out rather pretty out of a piece of paper, don't they? And all I've put in there is what they're looking for on somebody who's on antipsychotics. The QT interval is the bit where your heart has to rest and pump again. That's all you need to know. If it's lengthened, because the antipsychotics do that to it, it can cause life-threatening ventricular arrhythmia. Remember the A in front of it, it means without rhythm. That's all arrhythmia means, that your heart is not in rhythm. And it can lead to sudden cardiac death. So that's where wanting an ECG on initiation of dose, at a change of dose, and thereafter yearly. These are what the GPs should be offering. It's perhaps what we could be doing ourselves as well. It's not a complicated thing to do. The biggest complication is have somebody reading it. That's the thing. So that is down to the GP. The GPs are not necessarily trained in this. So you don't assume that they're going to know everything about what we're talking about and the antipsychotics. You know, they may really carry on prescribing it after a consultant psychiatrist, but we ought to all be a bit more aware of it. Factors such as smoking, obesity, and impaired glucose tolerance, that's, you know, people with perhaps diabetes, early signs of diabetes, are at much greater risk of death. Okay, so if on top of your antipsychotics you're already overweight, you're smoking, and you've also got diabetes, look how more dangerous this antipsychotic is and how much more we've got to support them to stay well and healthy. I won't go into the detail around why that happens, but just know that their ECGs are very essential. And as I was talking to Julia this morning about this, somebody perhaps with a profound learning disability, getting them up onto a table to do an ECG is perhaps quite a difficult challenge, but we do need to record perhaps with capacity they've declined, or they lack capacity and it's not possible, but we do need to start being mindful that we're capturing that, but we'll go through how that can be done in a bit. The other important bit to mention, which I think is important for everybody to know, and I'm not picking on anybody, I don't tend to smoke, but the effect of smoking on, I don't want to go into too much detail. Hang on a second. Oh, where's it gone? My gentleman who's cleaned up my PowerPoint has messed it all up, so it's not about ECGs. This is the effects of smoking. The hydrocarbons in tobacco smoke increases the metabolism of, you can read that, okay? I could go into a lot more detail around the dangers of smoking, but what you need to know is that if somebody is smoking on antipsychotics, they stop smoking, then the GP needs to know, or the prescriber, so they can adjust the dose. If you've got an individual who says they've stopped smoking and then the dose has been changed, but they go off for secret 10 cigarettes without without sharing, we need to know so that we can get that on the record for the GP or the prescriber, because they may require higher doses of medication. Okay, I won't go. I did do myself lots of notes to tell you what chemical makeups were, but I don't think I'll do that to you today. This is an important one, please, for everybody. It's a scary one, but it is one that we just need to touch on. There is a condition called neuroleptic malignant syndrome, and it's in the title. Malignant means death, really. So if somebody's had neuroleptic malignant syndrome, they can't have, the only treatment is to withdraw the antipsychotic. Okay, they can't have antipsychotics. So if you see NMS written in the notes and then they've gone off to have their prescription changed and they come back on antipsychotics, we need to be aware as their carers that actually, we must mention that because it's quite a serious condition. So please don't be too afraid of it. It's very, very, very rare. 0.5% of people who are on antipsychotics may get it. But unfortunately, out of the people that get it, 1 in 5 cases is fatal. Okay, so I don't want to be too scaremongery, but we do need to know about it. Now, if you look at the symptoms, diarrhea, sweating, high fever, unstable BP, ataxia is difficult moving, muscular rigidity, incontinence, confusion. If you haven't seen that that's NMS, does that make you think of anything else that they could be suffering from? Can anybody think what else that might make you think of? If you think of sepsis, and you all really ought to look around the sepsis awareness, we've all ought to be sepsis aware. Sepsis has diarrhea, profuse sweating, high fever. All of those things are very similar to sepsis. So it doesn't really matter whether you get them mixed up because you'll save their life. Either way, you'll save their life if you get help for them. That's all I'm saying. So if you're concerned that somebody's got these signs and symptoms, then it's an emergency requirement for care and treatment. Okay. Sorry if it's just me talking, but if it was in a normal situation, I'd have a lot more to in and fro in with conversation. We're nearly at the end, and then we can have some questions. So before psychotropic medication is prescribed, and I know you've already got individuals that you care for that are already on these medications, so this is what should have been considered before they went on them, but I doubt that happened if it was 10, 20 years ago. So they should have a physical health check, blood pressure, weight, ECG, and relevant blood tests depending on which medication. We were talking about behaviour baseline. That's difficult because you've probably taken somebody into the service that's already on the medication. But it is about sort of being mindful that, is it their behavioural or is it their medication, or are they medically unwell? We've got to just sort of be mindful of these things. If there's an increase in self-injurious behaviour, maybe due to pain from undiagnosed, potentially ear infection, urine infection, yeah. And a functional assessment. These bullet points come from the Challenging Behaviour Foundation, which is amazing. I'm sure you're already aware of that. And it's written for carers and advocates, really simple terminology for them to understand. So I've referenced them at the bottom. It's a brilliant, you can learn anything from there, from bunions to heart conditions to bipolar to schizophrenia. They've written everything to make it easy. So medication should never be prescribed for challenging behaviour without looking into the underlying cause of behaviour first. And I know that's important to all of you. So I was going to hand over to Juliet on this slide. I think Juliet, wasn't I?
Will you? Yes, that's fine.
Please.
Hello, everyone.
They've changed the format, Juliet. I can't follow it now.
Yeah, that's fine. So I know that's quite wordy, that next slide, isn't it?
Am I in charge of that
Yeah,
bit?
I can't
There you go.
do it. Yeah, so just some stuff to consider when, you know, if people are, you know, going there to prescribe stuff, you know, trying to find out why it's being prescribed, what it's for, what those side effects could be, because you need to be alert to that so you can respond appropriately should they have an adverse effect. How do we know if it's working? Keeping it under review, making sure you have that contact with the prescriber. Is it the least restrictive option? You know, and for me, and I know we've got this in the next slide, but it is always thinking about if you've got someone that's displaying new or increased behaviour, we have to rule out the health stuff first before we go there with medication, because like Amanda was saying, sometimes, you know, people that we support don't even recognise they're in pain or they're unwell, and we have to help support them with that. So I always say to everyone that I work with, always rule out your health, medical stuff, dental stuff before you go down that route. Absolutely essential. So yeah, so just making sure that we keep it under review, because we don't want people on this medication if it's not making a difference. And I see that time and time again where people are on medication for behaviour, but it doesn't tackle it. And we've got someone in one of the services at the moment where the LD nurse is going back to the prescriber to say, look, what you've put in has no positive impact, so we don't want him to be having it unnecessarily. So I think it is about challenging that, and making sure people are only on it if they really need to be. Yeah, and just making sure that we've got the info, because it's all there in the boxes. We just need to make sure that we get those out and that we make them legible for staff, because they're very wordy, but really capturing, you know, that the side effect stuff and what to look out for and what to do if someone is affected by that. I think that's really really essential. So yeah, so you can move on, Amanda. That's good, thank you. Yes. So obviously, you know, if someone's going on to medication, involve the people that are in the circle of support. I think you guys all know this stuff. The individual should be involved as much as possible to understand what it's for, why they need to take it, etc. You know, making sure family advocate and other people that are involved are there, support staff, your GP, psychiatrist and pharmacist. I mean, a psychiatrist are usually involved if it's antipsychotic medication. The GP tends to keep prescribing it for you, but actually we should be having reviews regularly with the psychiatrist, at least 6 monthly reviews over this stuff, because like Amanda's saying, the medication's highly toxic. You know, we know how detrimental it is to people's lives, so we don't want to just keep rolling on without that really good review process. And the pharmacists are really informative as well. So you've got any problems, like Amanda was saying, they take 7 years in their training. So that's a lot of information that they've learned. So and they're available more often, aren't they? Because you can just pop into Boots and ask to see someone. Whenever I've had dealings with the pharmacies, I've found them to be really helpful and very knowledgeable, especially if you're worried about sort of medications mixing with each other that can have a negative effect. Pharmacists know far more actually than the GP on that side of things. So, and they're available, you know, so use them. They're a really good resource. Thanks, Amanda. So yeah, we've said, I've sort of touched on this anyway previously with the slides, sort of thinking about, is it making a positive difference, the side effects, you know, making sure that we've got, you know, stuff in place to avoid having to use medication. How is someone needing to have it administered, things like that. You know, thinking about physical health, making sure we're recording it really well. I think, guys, if anyone goes onto something new, that recording is essential, because if we don't record it, we can't go back and say if it had made a difference, whether there is an impact. And, you know, I've been in a lot of services, and some services are really good at recording, and then other services fall a bit short. So I think it is, you know, for the management team to really be directive with the support staff and tell them what you need to be capturing. And then if you are concerned, what the process and the protocol is to follow that up. Yeah, and what is the plan for eventual reduction and withdrawal of medication? And I think from my experience as a manager, sometimes I've worked with people and the GP and the prescriber have wanted to cut medication out too soon and too quickly. And I think we have a duty of care to actually challenge that and say, yes, we want to do a reduction, but we need to phase it, because often I've seen people too quickly come off, then they've gone back on, and sometimes they've gone back on more. And that's obviously goes completely against what we're trying to achieve. So I think it is that, take it slowly, and then we can keep it under monitor. Because like Amanda said, some people need a little bit of medication to have a quality of life. And we're not saying that, you know, everyone's to be off it. We're just saying just to be on it if you need it, and just on the right amount to give you that quality. So I think, yeah, being able to do that. Thank you. So yeah, you can do this one, because this is one of your facts, isn't it, Amanda? Go on.
Yeah, it's just sorry, Juliet. Yeah, I don't know if this needs to stay in. It's just some powerful bits and pieces as you're reading these things. The role of health checks in finding and treating health problems. 10% to 15% of people with learning disabilities have challenging behaviours which result from physical health problems. That's a high percentage that are on medications that they possibly don't need. There's a small amount of available evidence that shows that health checks can identify health problems in a significant proportion of people who display challenging behaviours. Treating these health problems can reduce or stop the challenging behaviours. So we know that, don't we, already, that sometimes somebody with a urinary tract infection and constipation can look completely off kilter. And when we're talking about constipation, again, I'm using myself here, but when I was pregnant, I was constipated and I could have killed. Do you know what I mean? It wasn't just I need a poop. It was, I felt irritable, maybe so irritable that and that's not like me at all. I was agitated, I couldn't settle, I couldn't sleep. And so and that was a mild form. You know, our individuals can't explain how they feel. And if they have got constipation, it's not just the same amount of feeling as we have when we're a bit constipated. It's awful.
Amanda, can I just
add, of course. Yes, of course.
I see is really important. It's when the guys get constipated, especially people with autism, if it's painful to go, they're going to stop themselves from going, and you can get into this vicious cycle of where, you know, each day that goes, it's going to be harder and harder to go to the loo. So I think it's being mindful of that, but also with your bowel recording, what I'm coming across in some of the services is there's some good recording going on, but they're doing a week at a time. So on, say, Friday, Saturday, Sunday, someone hasn't gone to the loo. If we're not reflecting back on that, a new sheet goes in and starts Monday, Tuesday, Wednesday, we are missing big gaps where people haven't been to the loo. So, you know, we need to be really mindful that good recording, but also reflecting back is essential. And that's just my experience through being in services. I think we're quite good in places of recording it, but we're not good at reflecting back and making sure we've intervened when we need to. Because like Amanda, I've worked with someone who nearly died from being constipated, you know, and it's one of those never events. It should never happen, but unfortunately, you know, it does. So yeah, it's just my experience. Yeah.
Haley's sharing.
What's the next slide?
Sorry, Haley was sharing. Sorry.
Oh, sorry, I can't see anyone.
They can't hear you. Oh, Haley just wants to share something. We'll sit part. Sorry, she's got to get him.
Hello. Sorry, I was just going to say I haven't got my speaker on because I'm in the same room. One of our guys in one of our services was constipated, was on these medications, and it was also affecting his ability to get an erection. And sadly, he did take his life. That's how real it is. I'm sat over there and it's so raw, I can feel it. And I'm like, we're just going to have to tell you that is really real. And it was for him. I remember him crying outside the house saying, what's the point? I'm 59 years old. I can't get it up. I can't go for a poo, you know. So yeah, I just want to share that. Sorry.
No, it's very sad. And also, you know, especially with people that aren't so mobile, because we know exercise, drinking lots of fluid, and all of that helps us go. So when you've got people that are very static, that have poor diets, you know, that bungs us up. So the more that we can help people with those natural sort of laxatives, you know, prune juice, you know, seeds, good fluid intake and all the rest of it, it's got to be the best thing, and try and avoid medication in that way. But yeah, I just think it's being really mindful, because it is a, you know, it can be so harmful, and it can actually, you know, kill you off.
I think
so.
on the weight gain side of it as well, that you know, if we can all sit here the size we are now, and imagine being 8 stone heavier in a year. And my lovely colleague Rachel that I shared, she does public speaking and inspirational speaking as well. So, you know, she does allow me to share this, but she said in her conversations, of just explain to people what it feels like. She said, I've tried to kill myself because I'm fat, not because I've got schizoaffective disorder. She's coped with her condition, that condition that she's lived with since she was a young girl. That's not what causes her to be depressed. What causes her to be depressed is that she's 8 stone heavier than she used to be. And she just wishes that somebody, when she was younger, just took that little bit extra time to support her to eat less, to work more hard on her health promotion. So, you know, if we can just learn from that. Another one, just sorry, and then we're finishing on Juliet's slides. Again, this is just a bit to throw at you, just to try and actually the slides have gone off kilter. Can you read that top bit, Juliet?
No, because my picture's in the way.
Yeah, I'm in the way. I'll try and do it. 50. Can anybody else see it? It's just really to give you 56 adults with learning disabilities referred to a service for behavioural management. It was just that 13 of these people basically had a medical problem, and it wasn't behavioural. So whilst they were, I don't know if you've ever worked anywhere, but I've certainly been somebody who administers medication. I've had people come up to me saying, oh, Amanda, give him something, his behaviour's terrible, you know. And I'm thinking, well, what you're asking me to give him is something that's actually fairly toxic and poisonous, and what he actually needs is possibly more time. Sometimes I'll hear somebody say about somebody that I care for and love, and says, oh, he's been such a challenge today. And I think, no, his behaviour today is exactly the same as it was yesterday. The challenge is there's not enough staff on duty. The challenge is that you've got 3 other people with similar problems, and you're having to write up a lot of notes. So actually, it's not his behaviour that's challenging, it's the challenge of your job that's the challenge. Do you see what I'm saying? And in that case, it's medical. He's medically very unwell. So throwing a lot of antipsychotic medication and lorazepam and diazepam at him won't work. And it's a bit of percentages there. I know it's just percentages. So of that sample that was taken, they didn't have behavioural problems. They had 6% of the sample it was their epilepsy that was the problem. 13% was hypothyroidism. They needed thyroxine. Their thyroid problems were flaring up. 10% had gastroesophageal reflux. It wasn't nothing to do with the behaviour. 9% sadly had a bang on the head. You know, 9% were behaviourally disturbed because they'd had a head injury, and 9% were in chronic pain due to other serious conditions that had been perhaps not diagnosed. So I suppose it's just getting people to be mindful again of that sort of thinking of physical health before challenging behaviours. And what should we do, Juliet?
So obviously anyone that knows me knows I bang on about positive behaviour support. So if we get the support as best as we can for the person, meeting their needs, making sure health needs are met, communication and everything else, because, you know, behaviour is communication. People are saying something to us through that behaviour. It's just sometimes it's difficult to understand and decipher what that is because of the communication problems. But always think, if someone's behaviour changes or increases or stuff like that, always rule out the health stuff first. Always go there. Make sure that we've got all the good stuff going on, that we're keeping people in the green zone. What do they need in their lives to be happy, content and safe? You know, for me, it's a Costa coffee every morning and a nice bit of walking in the day, bit of exercise, someone to talk to, cup of tea and a bath in the evening. They all help keep me in that good green zone. So what do your guys need to remain in the green zone, to keep in that bit? Because that's what we're trying to achieve. And then what can we do if people come out of that? So if the anxiety is really getting high, if there's something that's causing them to get distressed, what can we do? What can we put in the mix to bring them back down? There'll be stuff there that you can use. You know your guys really well. So sometimes people have got focus of interest like Star Trek, Doctor Who. Can you bring something out and talk about that? You know, maybe a cup of tea in the garden. Let's talk about it. But it's thinking what works for your guys, because what you don't really want to do, you don't want to go the PRN way unless you really have to. And it's too late if someone's in crisis to give them PRN. You're just going to get yourself in struggle, because when they're in crisis, they're in that red mist zone. You know, they're not able to think clearly. So basically, at that time, you've got to think safety. So for me, it's about thinking what gives this person a quality of life, a decent life, making sure that we've got person-centered plans in place, making sure that people have got aspirations and goals, because we all need that in our lives, something to aim for, good relationships, positive interactions, lots of engagement. If we get all that good stuff going, if we make sure that our support is the best it can be, because sometimes, you know, I've come across staff that have that sort of face that looks a bit like a smacked bottom, you know, how that must feel for the person receiving that, you know, and how that will impact. So really looking at the support we're giving, and making sure that every day is a good day, because that's what's in our hands, isn't it? Whether someone has a good day or a bad day, the way we're motivated, the way we encourage that. So thinking about all that stuff, being really person-centered, making sure, I mean, Amanda's talked about health appointments, making sure that they're all up to date, that if someone is saying about, you know, their eyes, that, you know, get them to the opticians, the dentist, you know, hearing checks, all of that stuff, the screening that Amanda's been talking about, encouraging people to attend. I mean, there was a young lady that I worked with who really didn't want to go. She didn't really understand probably all of the in-depth bit on it, but what we did was we tried to talk to her about it. We spoke to her GP and other people involved, and actually they looked at the risk, and because she wasn't sexually active, because there was no history identified in the family, it was agreed as a group with her that actually the trauma of going through a cervical smear and the risk, they weren't going to put her through it. However, if she showed any signs or symptoms, or, you know, further down the line, we would never stop offering that to her. But in that moment, it was agreed that actually for her, the distress would be too much. Does that make sense? Nod if it does. Yeah. So, you know, sometimes the screening's there. We need to capture it if we can. Making sure we get medication reviews regularly. And the aim is always about reducing medication. I think evidencing that's really key as well, because we probably do have those conversations, but we don't write it up. And I think with the STOMP agenda and our promise and our pledge, that we need to be able to evidence that every time we're doing this, we are having those conversations with the prescriber about, can we reduce this? What do we need to do? And just make sure we capture that. Make sure we advocate for people, because we are often their voice in these situations. And if we don't speak out, then, you know, sometimes nothing will happen. And sometimes you have to fight the corner. You shouldn't have to. But like there's been some COVID sort of situations where people have had to really fight for people to get the treatment because they've got a learning disability or autism, which is terrible. You know, making sure that we share good practice and we learn our lessons. We do see quite a lot of medication errors. So as a team, we need to look at that. And support each other to get that better, because we shouldn't be making errors, and actually that has a huge impact. So, you know, doing our best to make sure that we put things in place to reduce that.
Michelle, have you got your hand up? Sorry.
Yeah. Hiya. Just a quick question. If you're doing like medication reviews, so I had it for all of my guys last week, well, 3 of them, because one's going under health tests and things. But the doctor wasn't very forthcoming in trying to reduce anything. How would I approach that the best way? Because like a lot of my guys have been on medications for some quite significant time, but they just seem to be more reluctant to reduce.
Julia, you take it on the
I'll take it, because I've come across this as well, but I've also come across the opposite to that as well, where they've been really keen to reduce and do it too quickly because of the STOMP pledge. So I think, you know, I don't know if your guys have capacity. Do they understand?
Not really, not especially around the medication and things like that.
So you're advocating on their behalf, aren't you?
Yeah.
So I think it is about, you know, getting that time with the GP and talking it through and really getting that understanding of what your guys are taking, why they're taking it, you know, the implications of that medication, and the fact that, you know, as a manager or whatever, you know, your commitment to making sure people aren't on medication when they don't need it. You know,
I've had this issue really, especially around pain relief.
Right.
I'm having some real difficulties when it comes to pain relief.
And
because
they're
I have
reluctant to prescribe, do you mean?
Well, I have it with one individual, but it does tend to use behaviours. So when he's not particularly happy about something, or it feels like he's not getting his own way, he will then state that he's in pain and he wants his pain relief because he likes the feeling from it.
Yeah.
So it's a very difficult one, because then when I've had the conversations with the GPs several times, in fact, and I'm saying, I'm not 100% sure this needs looking into, because I'm not 100% sure that it's actually pain related, because the pain generally moves. It's never in the same place.
Yeah. So
And
is
it's
it
always significant things. So, i.e., when his bets go down, all of a sudden he's in pain and needs pain relief.
Yeah. So do you think, Michelle, because people do behavior to, you know, there's a reason behind it. Sometimes it becomes quite functional. So is he using it to avoid something or to gain attention from you guys? Because if we can work out what's triggering him for asking for pain
He
relief.
likes the feeling of it because he's on quite strong cocodamol.
Oh,
Oh, okay.
Right. So he likes and he will come out with comments as to, well, do you think he'll give me morphine? Being a past addict as well.
Right. Yeah. That is quite difficult for you guys to manage. And if he's got capacity in asking for it, you know, you're in that position where if you deny it, are you denying someone pain relief and all
That's
that?
it. And
Yeah.
the argument I've had with the GP is that it's very hard to monitor and manage pain from another person's perspective.
Yeah.
And have to go off what that individual's saying, whether they're in pain or not. They believe that if they're stating they're in pain, so they will prescribe.
Michelle, can I ask what he originally prescribed it for? Because he would have originally had a reason for the prescription. Was he originally having a medical problem, or?
It's just always had it. He's just always complained of pain. Well, this particular person, the main issue is pain in the ankle. It's had thorough investigations on more than one occasion, and nothing can be found.
So he's not taking it over the amount that's prescribed. He's just
No, it is monitored because a bit risk of malnutrition and things as well, because he doesn't particularly eat very well without a lot of prompting and coaxing from staff. That it is actually documented, and it's down that he has to eat before having it because his risk of constipation and things as well, with it being codeine related. Obviously constipation is a big thing, so we do tend to manage it quite well with that fact. Sometimes it's only once a day he's having it, but it still doesn't prevent him continually asking.
If he's formed a habit around it, it's going to be the same as somebody, it's habit forming. And if he's doing that on a daily basis, that he's now formed the habit around wanting the medication. So the cause and the reason for wanting it seems to have perhaps moved on, and now it's the feeling that he wants from the codeine that's possibly what he's wanting.
And then he does ask for other things. So like he'll say he thinks if he complains enough that he'll get additional pain relief or stronger pain relief, because he's constantly asking for morphine and cannabis oil and things like that.
Well, I think if you get any pain managers onto it, because you could always refer him to a pain clinic. And the sad fact for him will be that actually the drugs of choice for serious pain are paracetamol and brufen. So that'll scupper somebody's. Sometimes they try and steer it into more thinking that they want morphine, but actually pain management for bony injuries are more likely to be not morphine. So he might push for that and actually end up shocked if you took him down the pain management route. So it might be worth asking for some pain management from the pain management clinic.
Michelle, what's his sort of day look like? I mean, is he a chap that's occupied? Is he easy to engage with, or not?
He's getting better. There has been some significant improvements with his engagement. Whereas before he does like a lot of music, he likes a lot of TV, but he has a very short attention span.
Okay.
So he can flick through programs all day long.
When he's out in the community, is he asking for the pain relief, or no, exactly. So what it could be, I'm not saying it is, but it sounds like if he's engaged in doing something really that occupies his mind, He's not thinking about the pain that he may or may not be in.
It's
So
usually, it is usually triggered, and there is clear evidence of things that with certain behaviours, and like when his bets go down or things like that. So that's when a clear indication of wrong. So when his bets go down, he wants to put another bet on because
Yeah.
he's obviously not going to win. He wants a reward at the end of something.
yeah, he sounds like he might have quite an addictive personality as well.
Yeah.
And some people, you know, they are more prone to that. So it sounds like that's part of him as a person. That sort of a
Yeah,
addictive
it's
sort of
definitely a
nature.
thing. I had this conversation with his previous GP, and the argument I had was that they were really reluctant to try and get off this or try something else because they didn't want to be prescribing an additional medication to manage that, and it's lesser of two evils.
Yeah, yeah, and it sounds like some days he's only having it once.
Yeah.
So
we
you know, if
manage
that
it quite well.
yeah, and I'd see that as quite successful than having it like 4 times a day. So it sounds like what you're doing, Michelle, is you're working really well with this guy, you know, to support him really well. So, you know, I think you're on the right track with your thinking, and the more we can sort of, if we can sort of distract him and divert him away from having it, which it sounds like you're doing, but being open and honest with the GP and recording it, Michelle, so if anyone does ask those difficult questions, you can say, you know, you are communicating with the GP. He feels this is the best option currently for this guy, you know, because it is really difficult with something like that. But it sounds like you're doing a good job.
Yeah, definitely.
Yeah, so that
Thank
sort of
you.
reassurance on that. So yeah, no, and you know, like we say, we can't always get someone off everything, and sometimes people need a little bit of something to have a quality of life, and if that little bit of pain relief or whatever gives him that sense of quality and that he can manage, then so be it. You know, I'm on daily meds for my migraines.
Yeah.
You know, and I take them because if I didn't, I would have migraines every day, and my quality of life would be appalling. So
I understand that. So yeah, we just treat it a lesser of two evils, but
yeah. But it's good that you're thinking that though, because that's always good to keep it in the mind that it's, you know, we need to be trying anyway.
Yeah.
Yeah, brilliant.
Absolutely. And I'd highly recommend the Challenge Behavioural Foundation. They write everything for their for people who care, you know, their carers, and for the individuals. So it's written in terminology. They do little cards that you can take to the GP, well, not cards, but you can print them off. So some of that, or the PowerPoint that we had around the list of things that you might consider when you go to the GP, it gives you a powerful position if you've got it already written down, the things you want to ask on their behalf or for them. So that behavioural challenge, the Challenging Behavioural Foundation, I found that really useful.
Yeah,
thank you guys.
Thank you.
Just this is the last slide, you'll be happy to know.
Yeah, last slide, guys. So I can only go from experience. So I obviously work in a lot of the services, and some services have really good medication files in place, and some are not so good. So I've come across some where a file is being shared, so you've got not just one person in there but 3 or 4, and to me that's a risk. That's like a medication error waiting to happen. So firstly, I would make sure everyone had their independent file with a nice picture that's up to date, and we have to make sure they're renewed very often, because I've come across files where you've got someone who was 20 years old, they're now 56 and they don't look the same. So just making sure obviously you've got their medication administration record, consent or best interest around medication if someone lacks capacity. We have to be really careful if you're doing anything covert. You have to have that recording in there and that agreement under best interest, because that is such a deprivation, and we could be in a lot of trouble if that isn't in there. How people want to take their medication as well. Sometimes we haven't always got that information about how someone's preferences is. Do they like a big glass of water? Do they want it off a spoon? Do they like to tip it out, and all of that? And I think we need to really make sure we capture that for the guys. Like we said earlier, the side effects, making sure they're clearly defined and legible in the file so that staff can see it, and look out for it. Because in those little bits of paper that you get, I know there's a special word for it, but the bits of paper that come out the boxes, it's very tiny in there. There's loads of information. So being really specific so staff can go to it and know what they're looking for. and how it impacts on the person that we're supporting. All the medical professionals involved, that should be in there so we can clearly go to those people. Your medication review agenda, demonstrate how we're working on reduction. Now, I did do a form, a template to share, but obviously you guys, you're the managers and the team leaders and all the rest of it. If it doesn't work for you, then, you know, let us know and then we'll decide on what will work. But I did do, and I'll share that at the end, just to make sure that we can evidence why you're giving PRN and the outcome of that. It shows us how often someone's having PRN. And then it also on the form, it's to go when you're doing medication reviews, that we can evidence that we've had that discussion with the prescriber about looking at reduction. And it just means that when you're asked by CQC or someone's coming in to audit you, you know, you can say we're signed up to this pledge, you know, and you can evidence the conversations that you're having and the plan that you've agreed with the prescriber on a reduction. So yeah, so it's all about showing that evidence. So yeah, and able to look for themes, because I did one in one of the services. We were looking at the PRN, and when we looked at it, they were having PRN every Tuesday, I think it was, afternoon. So with that, I said to him, what's different about a Tuesday afternoon? And it came back, it was something really simple. On a Tuesday afternoon, the person wasn't getting out and about. They were stuck at home. But by looking at the PRN and recognizing that actually PRN every Tuesday afternoon, what's the link? You know, we were able to so quickly identify, actually on a Tuesday afternoon, this person isn't doing very much, so they're disengaged. And when they're disengaged, they get bored. Or when they're bored, you get the behaviour. So as an easy solution, let's make sure that Tuesday afternoon's as good as every other afternoon, you know, and that they're doing something meaningful. So yeah, so that's a good way of tracking it as well. Because, you know, as well, and I know we haven't really talked about the menstrual cycle, but there's a young lady I'm working with at the moment, and I'm pretty convinced that her menstrual cycle's linking in with her behaviour. So I've asked the team to be really good at recording, so we then can then look at it, because there's something we can do about that, you know, and get away from the PRN. So, you know, it's looking at those themes and making sure that we understand if there's any links. Does that make sense? Yeah, good. Okay, so I think, is that the last one, Amanda?
Let me just have a look. Ta-da.
Yeah, just because we've got that form. I don't know if Ali can hear me, that recording form, or we can send it out.
Yeah.
And you guys can look at it. If you like it, use it, but at least have something that is on a similar vein. Is that all right? We'll send it out to everyone, can't we?
Thank you. I know we've sort of talked the way through, and I'm sorry if it's just been all me banging on and then throughout the first part of it, but I suppose I'd like some feedback as well about the actual presentation. We can't get away from some of the medical matters, because, you know, they are the true things that happen to people on the antipsychotics. So hopefully I haven't been too I don't know, emotional about that. But does anybody have any sort of comments that they'd like to make now, or any suggestions to make this better for going forward? We won't be offended, you know, if you feel it's too long or too much information. Otherwise, we're going to have to assume that it's okay.
Amanda, just to remind you that we won't put people on the spot today, but we will be sending out a link where you can comment anonymously.
Yeah, of course, that's fine. And you know, it needs developing so that I think the STOMP agenda is quite clear. You can get easy to read, everybody can print off their own. There's already so much information out there that's short and punchy, a one-page document, but it talks about reducing the medication, but it doesn't give really, in my opinion, the stuff that we were trying to talk about as the why it's so important, that we perhaps could do with knowing that. But not with scaring individuals. I don't expect anybody should really talk to their individuals about the scary side of it, about dying 20 years too soon. I don't think that's something that we should be really talking about with our individuals, but we certainly need to give them more support to not.
Yeah, but what I would just say is that CQC are very on the ball with this stuff, guys. So, you know, the fact that, you know, you've got plans in place and it's on your agenda, they will be pleased about that, because they will be asking. And we've had that in services already. So the fact is to just make sure you communicate this to your teams, that everyone knows that we're signed up to this pledge and this promise, what it means, what we're trying to achieve, so that when you get your inspection, CQC could talk to any of your staff and they all know, yep, we're signed up to that and this is what we're doing. And that will really like support you, you know, because it is a serious matter. Because like Amanda said, you know, people die a lot younger, and that is not okay in today's society, that people die 20 years younger. You know, that's so bad. So we have to do everything within our power. But yeah, making sure you disseminate this, you know, use the slides or the recording with your staff, so that they really get it as well, because it is so important. Anyway, that's me. I'll shush now.
Yeah. And thank you. I can't see everybody that's joined, and I think we've had about 15 people on the call. So I've met quite a few, but thank you so much. I think that'll be the end, unless anybody's got any questions. So we'll say goodbye.
Can these
Oh,
shared,
sorry, Michelle.
can these slides be shared? So we
Yes.
can use them in team meetings and
Yes,
things.
of course. Yes.
And
Yeah.
have information for
If, Michelle, there's a link on the intranet. Is Ali still on the call? There's a link on the intranet which we can remind you of, but all of our quality clinics, all the details are there.
Is that where we access the recordings as well?
Yes.
Yeah. I'm working last night, so I missed the first part of this, which I'm
And
worried about, because I thought it was 3 o'clock it started, not 2.
Some of the notes underneath are just a bit wordy, but it's useful just to maybe just see what I'd written underneath. Just to, the PowerPoint's a bit wordy, but it had to be a bit, really. I'm not quite sure.
Yeah, no, that's fine. Thank you.
And nice to meet you all, and take good care.
Thank
Fight a
you.
good
Bye.
fight.
Bye, guys.